Okay, guys, I think we're going to go ahead and get started. I'm an ER nurse in Alabama. I'm also a full-time clinical consultant for Baxter, formerly Cheetah Medical. I am the president-elect for the National Association for Hispanic Nurses, the Alabama chapter, and my background in ER nursing has been in a level 1 academic center. So I think we can usually go back and kind of identify our first experiences with particular technologies or new concepts. And for me, I'll never forget when the Cheetah rep, and at that time it was such a small company, it was not a nurse that was the clinical that came in. And so they were talking to us about this new technology, this hemodynamic monitoring that we were going to do in the ER. And I remember we were just like, I think you're in the wrong unit. We don't do this here. And so for us, it was really tough. It was a tough sell for us in the ER because it was a lot of new information that we were not conditioned to looking at. And so when we started using it, it was slow going to find out where the good fit was going to be. There was this one particular night that it was about 2 a.m. I used to work night shift, that this patient comes in and she was in just tripod breathing, obvious respiratory distress, like you're already getting the airway cart, you know where it's leading. This patient had not a great history that we were able to get. Of course, she wasn't a great historian because of her airway issue. What her husband was able to tell us is that they had been traveling by car, multiple states, a lot of sitting, that she had a history of congestive heart failure, although she was adequately managed medically. This is kind of what we were able to get. So we put her on the monitor, on the bedside monitor. Blood pressure early on was hypertensive. So never once were we really thinking like a hypotensive state, hypovolemic shock, anything like that. Statting in the 80s, systolic was 170s to 190s, heart rate in the 150s, and obvious respirations were 30s to 40s. So the physician goes ahead or the fellow at this time goes ahead and puts the patient on BiPAP while we're trying to figure out what to do. Of course, we're getting labs, lines. We're starting to kind of throw tic-tacs at that whale of a blood pressure to get it down a little bit. But not a whole lot aggressively being done right now. What we did do was immediately hold fluid. Why do you think we held fluid and didn't consider? There's 2 reasons why we wouldn't have even considered. Yeah, so hypertensive and CHF. No one's thinking it. In fact, even still, sometimes I have to catch myself. I see something present like this and you automatically want to think that patient's not going to benefit from it. So for the first several hours, we never considered fluid. What we did do was I had the 3rd-year resident do an IVC collapsibility. Do you guys know what IVC collapsibility is? It's a bedside echo exam that some ERs do as a method of assessing volume status in patients. But to better understand this, it's a subjective measurement, so it's dependent on the user's skill using it, and it's a snapshot. So it's a static measurement, what their volume status looks like at this time. Little known fact, when you have BiPAP on a patient and you do IVC collapsibility, because BiPAP increases intrathoracic pressure and splints the vessels, it's going to make you look full on echo. So when the 3rd year did the exam, she said that the patient looked full, looked like they didn't need any volume. So that was, again, tossed out the window. A few hours later, the fellow comes in and he takes a look and says, well, actually, I don't know. They are on BiPAP. It's tough to tell. They get the attending, so this is 2 physicians that have 2 different readings. The 3rd physician that comes in does a bedside echo on this patient and sees that the patient actually may look a little bit flat, and to consider that BiPAP is on. So at this point, we have 3 different physicians that did 3 different exams and got 3 different results. So as the nurse, I'm like, so what are we doing? What are we going to do? Since no one's agreeing here. So we get the Cheetah. That's when the attending's like, let's go get that Cheetah monitor and it'll be the tiebreaker, right? So we put the patient on the Cheetah and we did a passive leg raise on this patient. That's in our ER, we did a lot of passive leg raises. So we did the passive leg raise. This patient was 37% volume responsive. And in just the 5 minutes between start to finish, between getting the passive leg raise and completing the test, When we recycled the blood pressure for the first time in about 2.5 hours, her blood pressure came down from the 170s to 190s into the 130s, 140s. Heart rate over the course of the 5 minutes that she got her own auto bolus, her own auto transfusion, right? Her heart rate came down. So now, of course, when we sat her back up, because the volume goes back down to the legs, you saw the heart rate kind of come back up, and you saw the blood pressure kind of go back to over the next 10, 20 minutes. So what we were able to see immediately, not just that this patient was 37% volume responsive, letting us know that, hey, it's actually safe to give fluid if we want to give fluid, A, but B, she responded almost immediately. She was so dry. She responded almost immediately to her own auto bolus. Interestingly, when we go back to why were we thinking about not giving fluid, when we think about CHF, what are clinical manifestations that would tell us this patient is in an acute exacerbated state? Maybe, lung sounds are off. We might see that they're puffy peripherally, pitting edema, right? She had none of this. So we get kind of, and maybe you guys can relate on this with me, but we kind of get into this habit of seeing something show up on history, and we get tunnel visioned one way or another how we're going to approach this patient. So when we took a step back and we looked at this patient had we didn't know what we were doing with this patient. Is this PTE because you had a DVT that got thrown because of all this travel you've been doing, right? Is this an exacerbated CHF state versus question mark, question mark, question mark? We didn't know what was going on because she wasn't responding to any of the medical interventions. Negative chest x-ray, negative D-dimer, which is like, honestly, maybe the most surprising thing that it was negative, right? Doesn't take the wind blow sideways and you have an elevated D-dimer. Nothing about our exams, our blood work, was showing very much except that she had an elevated white blood cell count and borderline high lactic. Still nothing really impressive. What we ended up finding out later on, because we drew in the ER because of the fever, she did have a fever, was that she was more than likely in an early septic shock stage. Remember in nursing school we talked about no shock, compensated shock, decompensated septic shock, right? When we think about the shock that we see and treat as ER nurses, it's the one that's circling the drain 15 minutes before shift change, right? The one that comes in, their blood pressure is really low, they're super tachycardic, they look like that septic patient we're used to seeing, but there's a whole other side of sepsis that we sometimes don't see, and it's the one that's sitting at home that's not quite come into the ED yet. And those patients may actually clamp themselves down. We have compensatory mechanisms. One of these is tachycardia, and the other one is that we will increase our vascular compliance, right? We will clamp ourselves down in a low volume state. So think of this as when you put your thumb on the garden hose, even though I haven't opened the faucet up more, I've increased the pressure with which so I can perfuse the garden. So in this particular case, we think this is what was going on with this patient. What's interesting is that we were about to intubate this patient, which would have bought her a bed in the ICU, which brings with it, there are plenty of risks that come with an intubation, even in a patient that needs it, right? Because we were able to establish that the patient was in fact volume responsive, and she responded so well to the volume we gave her after we had evidence, objective evidence versus the 3 subjective ED physicians, right? We were able to admit her to a step-down bed and not an ICU. She was able to come off BiPAP before she ever even left the ER. For me as an ER nurse, that's maybe the first time I had ever participated so largely in the outcome of a patient. Not just trauma bay, they're bleeding out, from a monitoring standpoint that I placed on the patient, that I got the data on, that it felt like I was sitting at the table having a conversation that I had never been a part of before. And so for me, it was like game changed. I went to my charge nurse's office and I was like, we got to have one in every room. Why do we only have 2 of these? Like, this is a 60 bed ER, like what are we doing? And so that was my big, and then I just had to learn everything I could learn about hemodynamic monitoring and how to approach blood pressure, which we're going to play a little game here in a minute. I think it was part of your pre-game, the QR code. what part of a blood pressure tells you if a patient needs fluid? Is it the systolic or the diastolic? Or is it the MAP? So let me restate. Which part of a blood pressure, systolic, diastolic, or mean arterial pressure, tells you that your patient needs fluid? There's no wrong answer. So there's actually no part of a blood pressure that tells you that the patient needs fluid. When we look at a blood pressure, what we're seeing is information about how well we are managing perfusion. So if it's low, what that tells us is your patient is hypoperfused, low, right? We're not perfusing the end organs well. But there's actually no part of it that tells us give fluid. There's no part of it that tells us give pressor or go up on that pressor that's hanging when you walk in at the start of your shift. And there's no part of it that tells you to give an inotrope. How easy is it though, when as an ER nurse, I see this, what did I just start 2 of? You just got 2 large bore IVs and I'm slamming in 2 liters of fluid and I'm getting a high five from the resident while he goes and he puts in that order for fluid, right? I mean, traditionally, this has been the case. I think we've gotten a lot better in emergency medicine and nursing about being much more diligent with fluid administration, but still typically, and if you ask nurses or physicians in any critical care area this question, they will respond the same way that you did, the same way I did, right? We start with fluid. When fluid doesn't work, then what do? In the ER, we probably gave more fluid, but then eventually, when we hang it up with fluid, yeah, about 4 or 5 liters in, then what do?
Can you just put that on a pressure bag?
Yeah. But she's right, pressors. Eventually, we'll move over to pressors. And the IC is a little bit different. They will actually jump to pressors sooner, but they will ride the pressor train long and hard. They'll stack 2, 3 pressors, and then we kind of end up in a different direction. When you've walked into a shift and you see a patient on pressor, if their MAP is below 65, do you need to leave that room to go get permission to go up on that pressor? How are we conditioned? Everywhere. That if it's less than 65, you go up on that pressor. And when I max this pressor out and I go and I tell the resident or the attending, what do I think is going to happen next? Probably stack another one. No part about this right here tells you that the lever you're pulling is the right lever. We need more information. So think of it this way. Macro hemodynamics, that's your blood pressure, that's your heart rate on the monitor. It tells us there's a problem, right? But if you want to know why there's a problem or which lever to pull, that's micro hemodynamics. You need to get a little more information. And I think a lot of you guys are doing this, right? So in 2017, Dr. Paul Merrick, he published a study where they identified fluid as an independent risk factor for mortality. The study included patients that came into the ICU from the ED, and what they found was that for each liter of fluid above 5 liters, mortality increased by 2.3% with an associated cost of about $1,000. So 2.3% doesn't sound like a lot, right? But how many times do we get patients from out in the field who are already a liter or 2 deep before they get to us? And then maybe they're still hypotensive, right? And so we've already agreed that if I see a low blood pressure, I'm going to start with fluid, right? How hard do you think it is for us to get to, for every liter above 5 liters? How hard, before they even leave the ER, how hard is it for me to hit the 5 liter mark? It's not that hard. And interestingly, when they go to the ICU, how hard do you think it is for them to exceed that number if the patient is still hypotensive? Because you know what we found? Everybody starts over and starts with fluid. So you go 2.3%, next liter 6, 2.3%, next liter 7, 2.3%, and all of this within the first 24 and 48 hours, you may not even see the negative consequences of going above this number while they're in the ED. We often don't. Sometimes we do. You get a therapeutic intubation for that flash pulmonary edema. Oops, a little too much, too quick, right? But sometimes we don't see them. And so this is where it becomes really provocative for me, having been able to kind of cross from not just being in the ED, but following and teaching the ICU as well. I'm suddenly seeing what those consequences are for these patients that we never get to see again when we send them upstairs. And it's AKI, it's cardiopulmonary consequences, therapeutic intubation, CRRT, increased length of stay, not just cost, but morbidity and mortality. And that, like, as a nurse, like, even talking about it it makes me cringe. So there was a meta-analysis that was published. Approximately 50 ICUs participated in this. It's over 2,000 patients involved. What they found, and if we look right here, this column, and it's like study, 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 right? They're stacked. This column right here shows how often, when they did a passive leg raise, when they did a dynamic assessment, how often was the patient volume responsive. So you see numbers like 41, 51, 49, 57, it goes on and on, all 50 studies that they came together and they averaged. And what they found is approximately 50% of the time when they do a dynamic assessment to establish, is it actually safe to give fluid right now? Not whether they should, can the heart tolerate it and move it? Approximately 50% of the time, it was a go. That means the other 50% of the time, when we're not checking. So what I process this is, let me get a quarter. And every time I go and I hang a liter of fluid, if I'm not checking, I'm going to flip that coin. And those are my odds as to whether or not what I'm doing for this patient is actually going to increase their stroke volume and thereby increase their cardiac output and their perfusion safely, right? So this is called the Bellamy curve. It's an illustration of what it looks like when we give too little and too much fluid. Too little fluid, you see things like tissue hypoperfusion, hypoxia, organ failure, insufficient perfusion. Too much fluid, similar. Tissue edema, organ failure, increased ICU vent days, increased mortality. The way I see it is, don't give enough fluid to a patient, dead right now. Give too much fluid, dead a little later, right? What we're looking to do is get in the sweet spot here. How do we do that? How do we figure out what a patient needs? Not too much. Maybe she needs 500 cc's, right? Maybe I need 2 liters. Maybe Josh in the corner, he's not volume responsive. In fact, he's negative. He needs a cardiac consult, right? How do you know? We check, right? Dynamic assessment. You can do a passive leg raise or a bolus. So IV fluids are drugs. We know they are. We've always known they are. For whatever reason, we've been conditioned since our infancy as nurses in school that volume is quick, it's cheap, it's easy to throw at a patient that looks hypoperfused. It's a quick stand-in. We can pull the volume off later if we had to, right? But we're trying to get away from that because we're seeing a lot of not just increases in cost, but the mortality issue, the morbidity. Even if you survive this stay, what's your kidney life look like, right? Do you have permanent heart dysfunction? There's a lot of studies that are showing that maybe there's not as many septic patients dying because of sepsis. How many are dying actually because of the mismanagement of it, because we're missing pieces or we're not getting enough data? So how do we assess for volume responsiveness? Well, there's 3 ways. You can do a passive leg raise, a bolus challenge, or trending therapy. So provided that your patient has legs, I'm sure they always do, right? We would do a passive leg raise. You lay your patient flat, you lift the legs. It's a 3-minute passive maneuver where 200 to 300 cc's of their own blood volume go back to the heart, and we're able to measure the effectiveness, how well your heart can move it forward. If they don't have legs, if they have some reason why they can't do a passive leg raise, or if it's just your facility's preference to do a bolus, and that's fine too, you can do a 200 or 250 cc or 500 cc bolus, which is a direct challenge to the heart, in which case you don't have to reposition the patient at all. It's just quick and easy. If for some reason neither of those are an option, say it's a bilateral or a BKA, right, and with an EF of 10%, so neither one of those is something we really want to look at, we can trend. Fundamentally, when we give a patient fluid, the whole point of it, if we go back to like anatomy and physiology, when I give a patient fluid, the whole point of me giving it is to increase circulating stroke volume, right? If I pour water into the cup should become more full. So if I increase stroke volume, more volume into the heart should equal more volume out of the heart, right? Cardiac output should go up. And if I can successfully increase stroke volume and cardiac output, I've successfully increased perfusion. That's the goal. So if at any time you're giving fluid, and you're increasing or maintaining stroke volume, at the very least maintaining, we should be increasing, right? Then what we're doing is very likely safe and helpful. But if at any point you're giving volume and your stroke volume is going down, we need to take a step back, right? That's the wrong direction. Maybe I need to pull another lever, right? So this is, and I don't know, how many of you guys have this in your facilities? Have the cheetah? Do you guys have the badge cards? Have you seen them? I never lose my badge because that's how I get paid, right? So, but sometimes we don't bring our phones in there. We're not supposed to. We don't have all those resources. But it's a really nice, convenient way to take a look at passive leg raise, step by step, the bolus, step by step, your options, and then if you're greater than 10%, you're a volume responder. If you're less than 10%, you're not. And so it's really a very simple one or the other test to find out if your patient can tolerate the volume you're giving.